Hi, everybody.
Hi, Michael. Leslie's muted because she's testing YouTube.
Okay. I'm going to test screen sharing.
Looks good.
Michael, can you stop sharing for a minute so I can see everybody when they come in? I'm just seeing your screen right now, and
You should be able to expand your view, Leslie, and see everybody. No? Okay, I'll stop sharing.
Hang on. No, wait a second. Yeah, I just have a laptop, so I don't have as big of a screen to see everything, even if I expand it. So I'm expanded all the way out. We cannot start until we have a quorum for our attorney. So hopefully a few more people will come. We're supposed to have 13, I believe, is who those of the people that responded to me. Some just sign in and then I find out they're attending. So I hope they all attend. Okay. Good morning, Ms. Massey. I see Tom Clark has joined. Good morning.
Good morning, Leslie.
Good morning, Mr. Greenway also, Mr. Clark. We'll get started as soon as we have a quorum. Good morning, Ms. Lissack.
Good morning.
Mr. Farrell, good morning.
Good morning.
We'll be starting as soon as we have a quorum. Almost there. Morning, Kyra. I said good morning to you earlier. I don't know if you heard me.
Good morning.
Glad you could make it.
Happy Friday.
Yeah. Happy Friday. Ms. Stasso just joined. Good morning.
Morning.
We can get started as soon as we have one more of our stakeholder committee members join. Oh, there we have Dr. Amar. Good morning. We now have a quorum, so we're going to begin. I'm going to start the webinar. So good morning. If you could turn your cameras on, that would be great. I'm going to call the meeting to order. Good morning and welcome to the PPC Stakeholder Advisory Subcommittee meeting. I would like to welcome you all here and let you know that in the absence of an executive director, which they have not found yet for us, I'm going to be hosting the meeting with Michael Baylett from Baylett Health and Stacy Yee from Baylett Health. Just so you know, I'm not going to be monitoring emails or chat during this meeting because there's just too much going on. I can't do it all, but I would like you to know that if you have a question, please don't hesitate to raise your hand. And I would like to start roll call. So I'm going to begin. Dr. Angela Amar.
Here.
Carla B. Elizabeth Bullhouse is excused. Chris Bossy is going to be attending late. Is Phil Burrell here yet? Okay. Tom Clark? Are you on mute still, Tom? I saw you earlier. Oh, I see you there. I know he's listening. He's here. Jody Dominic? Vance Farrow?
I am here.
Joseph Greenway?
Here.
Joan Hall?
Here, thank you.
Is Maya Holmes here yet?
Maya's in the waiting room, waiting to be let in.
She is. Give me a second, please. I apologize for that, Maya. I've made you a panelist. Maya, can you hear me?
Yes, I can. Good morning.
Morning. Shayla Holmes. She is excused today. Lawrence Lerner.
Present.
Ashur Lasek.
Present.
Karen Massey.
Here.
Tom McCoy.
I am here.
Kyra Morgan.
I'm here.
Stacy Sasso.
I'm here.
Todd Sklamberg is excused. Is Jennifer Wakeham here? No. Okay. And Bill Welch.
Present.
Okay, we have a quorum. So we can start. All right. The first order of business, I would like to again welcome you here. And if I could accept a motion to approve the minutes from October 1st, our meeting on October 1st. Do we have anyone that would like to make a motion to do that?
This is Stacy. I'll make a motion.
Okay.
Tom Clark also.
Stacy Sasso, Town Clerk. Is there any addition or change or anything like that? Does everyone agree to approve these minutes?
Approve.
Okay. No opposition. Okay. All right. Now we're going to go to public comment. Do we have anybody that would like to make public comment? I show one attendee here. Any public comment? Okay. Then I think we're going to go right into Michael Baylitz's presentation. Thank you.
Thanks, Leslie. Good morning, everyone. Nice to be with you again. We have a very full agenda for today. These are all of our agenda topics that I want to cover with you. It's fairly technical content when it comes to measurement of performance against cost growth benchmarks. So I just want to forewarn you, although I will try to be as clear and non-technical as possible. The content that we have, depending upon how much conversation takes place, may be more than we can get through today. So if we do not get through everything in this meeting presentation, I want to invite you to share in writing any comment that you have with Leslie following the meeting, and ask that you do so by next Friday so that we can share with the Patient Protection Commission the feedback that you want to convey to them. They next meet on February 16th. I want to start by just reviewing with you the benchmark methodology and value since the governor has established the benchmark since we last met. So when we last met, which was way back October 1st, there was agreement among you and among the commission that the gross state product and median wage should be used to calculate the benchmark value. You didn't have consensus on the value. There was a preference for a value that was somewhere between 2.4 or 2.8% for 4 or 5 years. Most people preferred a value that remained constant over the time period as opposed to changing. And your recommendations and those of the commission were conveyed to the governor's office following the aforementioned October meetings. So after it was conveyed to the governor's office, the governor on December 29th issued an executive order establishing cost growth benchmarks for the years 2022 through 2026. And you can see here the actual language from the executive order. Consistent with your recommendation and that of the commission, the benchmark values were established by consideration of both median wage and gross state product. The benchmark value was calculated as a weighted average of those two economic indicators, with the weighting, as you can see, changing over the course of 5 years. And so these are the benchmark values right here. Executive order says that the benchmark applies to all healthcare markets and populations in the state. I'm going to share some of the other language from the executive order just in case you're not familiar with it. It directed state agencies to monitor healthcare spending growth across public and private payers and report at least annually to the governor on spending growth. Importantly, B, to engage insurers, providers, community partners to develop strategies to help meet the cost growth benchmark, which is also referred to as, the values are referred to as a target, using strategies that are data-based and practicable. Ensuring that consumers and businesses benefit from the positive impact of the benchmark. And then there to be reporting in the fourth quarter of each year on performance relative to the benchmark at the state level, the health insurance market level, defined as commercial Medicaid, Medicare, and Medicare Advantage, and the individual payer level, and also at the accountable care organization level for entities of sufficient size. Now, the executive order doesn't define accountable care organization. We previously have talked about measuring performance of large provider entities. I think that's what's meant by accountable care organization. And then finally, the commission is directed to make a recommendation for cost growth benchmark values for years 2027 and beyond in the fall of 2026. Oh, I'm sorry, there are a few more terms I got to cover. It specifically names the Division of Insurance and Department of Health Human Services as being responsible for working with the PPC and its executive director to implement the order. It says that should the commission find there have been significant changes to the economy after the effective date of the order, it may recommend to the governor changes in either the benchmarks or in changes to the manner in which benchmark performance is assessed. Okay, so that is the executive order. Anybody have any comments or observations you want to share before we move on to our discussion of reporting against the cost growth benchmark? No? Okay. So we're going to spend the remainder of our meeting talking about how to report performance against the cost growth benchmark, especially at the insurer and large provider entity level, and how to do so in a way that is fair and appropriate. I want to note, just as a reminder, that what we're talking about today is benchmark analysis, which is on the left side of this slide. So we're talking about measuring change in healthcare spending over time on a per capita basis using aggregate data from payers, public payers and private payers. And staff from the Health and Human Services Office of Analytics have been assigned to perform this work. This is separate from analysis of claim data to understand what's driving spending and spending growth. That analysis will eventually be performed using the all payer claims database once it's constructed. But until then, that analysis is going to be performed using Medicaid and public employee benefit plan data. Okay, so we're not talking about the data use strategy today. We're just talking about the benchmark analysis. We will talk about the data use strategy though in future meetings. So reporting when it occurs, and we've talked about this before, will occur at 4 levels, and the executive order specifies this. So this is just a graphic presentation. Market level performance, Medicaid includes fee-for-service and Medicaid managed care, which is Medicare Advantage. I'm sorry, down here is Medicare, fee-for-service, Medicare Advantage. Medicaid is Medicaid fee-for-service and Medicaid managed care. And commercial is both fully insured and self-insured populations. Okay, reporting is done by Medicaid. The reporting of payer performance will be by Medicaid MCO, Medicare Advantage plan, and by commercial carriers. And all of their data will be used to measure the performance of large provider entities. So I want to give you a few examples about what reporting looks like in some other states, and then we'll get into some of the technical issues about how to do this and do it well. So this is an example of reporting at the state level. It comes from Delaware. You can see they reported for calendar year 2019, overall state healthcare spending was $8.2 billion, and they broke it down into Medicare, commercial, Medicaid. NCPHI is the net cost of private health insurance, which is commercial insurer, admin and profit, and then Veterans Health Administration. This example from Rhode Island is measuring their commercial market trend for 2019. Their cost growth benchmark was 3.2%, actually still is 3.2%. Their per capita trend that year was 4.7. So they reported what was the value of spending per member per year, $6,000 per member per year in 2019. This excess of their cost growth benchmark, the 4.7% exceeding 3.2%, equates to $32 million of excess spending that year. And this is just how they chose to report it. Just giving you examples, none of these recommendations or prescriptions. This is an example of reporting at the payer level. This comes from Massachusetts. Their cost growth benchmark was 3.1% for this year. And each of these circles represents an insurer. So you can see most of their insurers were below the 3.1% benchmark. There were a couple above, one right on the line. The size of the circle indicates the market share of the insurer. This is an example also from Massachusetts at the physician group level. That's how they are measuring provider performance. So these are the physician groups listed down here on the x-axis. They reported separately for their 3 largest insurers. So you can see that, for example, for this this provider right here, Partners, there was negative trend for 2 of the pairs and positive trend for 1, although for all 3 cases, it was below the benchmark of 3.1%. Again, this is not a recommendation. This is just an example of how other states have reported out performance. So when we're reporting performance at the provider organization level, we want to make sure that the population is sufficiently large so that we can be confident that the measurement is accurate and reliable. We also want to make sure that when we're measuring benchmark performance for provider organizations, that the provider organizations are judged to be responsible for meeting all of a patient's needs. So these might be medical groups or health systems or independent practice associations that can engage in total cost of care contracts. The commission will be discussing how to define and identify provider entities whose performance will be measured against the benchmark. So let's talk about this process of connecting members to clinicians and clinicians to large provider entities, because it's through these steps that we measure performance of large provider entities against the benchmark. So there are 2 questions here. How should patients be attributed to a clinician? And how should clinicians be organized into large provider entities for the purpose of measurement and reporting? Because we're not measuring the performance of individual clinicians relative to the benchmark. We're only doing large provider entities, but those large provider entities are comprised of groups of clinicians. So first, we're connecting patients to clinicians and then clinicians to larger provider entities. Any questions about anything that I've discussed so far? If at any point you've got a question or concern, please just raise your hand and I will be happy to address whatever you would like to discuss.
I have a quick question, and I think you have covered this before, but how would out-of-state clinicians be captured? Or are we going to get to that?
So the measurement of performance, thank you, Ishwar, for the question. The measurement of performance against the benchmark will just be for Nevada-based provider entities. But if they're spending for a Nevada resident during the year that takes place out of state, that spending will be included in the calculation of spending. Because our focus is really on spending for healthcare for state residents, regardless of where they receive services.
Thank you.
Yeah, thanks for the question. Okay, so this is just a graphic depiction of what I've been discussing. We've got spending for an individual member of a health plan. The member has to be attributed to a primary care provider. The primary care provider then, if possible, is attributed to a large provider entity. I say if possible because not all primary care providers have a formal relationship with a large provider entity. Okay, it's only going to be some of the primary care providers in the market. So insurers are going to report data to HHS by large provider entity. There will also be reporting by insurers for members of their health plans who cannot be attributed to a primary care provider because they either didn't seek any care during the year, or they sought care, but it wasn't from a primary care provider. Let's just say they went to urgent care and saw a specialist. And then finally, insurers will report on spending for members who have a primary care provider relationship, but that primary care provider is not attributed to a large provider entity. So we have really three categories of spending. Spending for members whose primary care provider is part of a large provider entity. Spending for members whose primary care provider is not part of a large provider entity. And then members who either have no spending or they didn't seek any primary care during the year. So for all of this to work for measuring large provider entities, we need to attribute members to a clinician for the costs incurred during the year. Insurers do this routinely for value-based contracts where provider entities are held accountable for quality and or cost of care for patients. So this is a really common exercise for insurers. They also attribute members to clinicians and provider entities for other reasons. And states do so, quality improvement organizations do so. This whole idea of attributing patients to clinicians or provider organizations is quite common. So being attributed, what does this mean? Well, I can tell you what it doesn't mean. It doesn't mean that the member was required to see the clinician. It doesn't mean that the clinician delivered all the care the patient received. Okay, but what it does indicate is that the clinician had a relationship with a member of that health plan, and that the clinician in some manner helped to direct the member's care. So there are two approaches to attributing members to clinicians. One is to adopt a common methodology where insurers agree upon that one methodology and they all apply it for purposes of reporting spending by provider entity to the state. The strength of this is it supports comparisons of performance across insurers. The con is it adds a layer of complexity to the process because insurers all use slightly different attribution methodologies. And I say slightly different because we've done some analysis in other states where we've compared them, and they're not the same. They're not a lot different, but they're not exactly the same. So the other method is to say, we're just going to let insurers use their own methodology when they report to the state, and they'll use whatever they're employing in their value-based payment contracts or for other purposes. This makes reporting a lot easier for insurers, but it does make it a little bit more difficult to make provider comparisons across insurers. Right. So I'm presenting these two options to you because I want to share with you what the PPC had to say, and then I want to ask for your input. So first, what have other states done? Well, other states are all using primary care attribution, and they've all decided to leave the methodology up to each insurer. So they have not tried to impose a common approach for insurer reporting. Massachusetts and Oregon did add some additional specificity. However, they require that each carrier follow a hierarchy in their attribution. So member selection would be first. So if there's an HMO product that requires PCP selection, for example, that would be the first rule in the hierarchy. And then if there's a contract arrangement that attributes a member to say to an ACO, that would be the second one. And then utilization algorithm that looks at most frequent or most recent visits with PCPs. Okay, so that's what other states have done. I should mention Washington also recently adopted the same approach as the states you see in the top bullet. So we asked the PPC during its last meeting, just last week, what they wanted to do. They agreed to recommend allowing insurers to use their own attribution methodology, but also to ask each insurer to disclose what that methodology is, to be transparent about it. They also recommended that the state perform a future analysis to see whether differences are substantive enough to warrant a common methodology in the future. So my first question for you of the day, and I will have others, is do you what's your feedback on what the PPC decided? Well, or what I would say they tentatively decided, because we're seeking your feedback today to convey back to them. Should insurers be allowed to use their own patient attribution methodologies? Should they use their own but specify a hierarchy? Or should state require a common member attribution methodology? Anybody have a thought?
So this is Kyra. I can chime in here. And what comes to mind, I agree with the decision from the PPC to allow insurers to use their own attribution methodology. And the reason really is just that I think it would be pretty difficult and would potentially delay the analysis to make everyone follow a standard methodology. So it seems like maybe perfection would be the enemy of good in this situation. So that's my feedback. I'm not sure if there are others who would disagree.
Mm-hmm. Thanks, Kara.
This is Maya. I would just weigh in. I think we felt similarly and thought that the PPC took a thoughtful approach of looking at it over time as well as it evolves.
Thank you, Maya.
Michael, I have a question. I'm wondering, it states that it says it's asking each insurer to disclose that methodology. Is that something that's going to be required, or is that just simply suggested?
So the PPC makes recommendations to the state. The state then has to take action. So I think the PPC's recommendation is that the state should require insurers to disclose their attribution methodology.
Okay, thank you.
Anybody else have an opinion? No? Okay. Then let's move on. So the next question is how to organize clinicians into provider entities. So we've got a whole pool of primary care clinicians. How do we identify which larger provider entity they are in some way connected to? There are two general approaches for doing this. The first is to utilize a statewide provider directory. Massachusetts and Oregon do this. So that means that the state has in some manner mapped each primary care clinician to a practice, a medical group, and maybe some larger provider organization. Second approach is to perform this type of attribution based on contracting arrangements. This is what Rhode Island and Connecticut do. So the insurers report based on the ACO contracts that they have, which define which PCPs are part of which ACOs. Okay, so these are the two models in place thus far. There might be some other approach that I can't identify, but these are the two approaches in use thus far. So this is example from Massachusetts. They map individual NPI numbers to physician groups. Provider directories can also use tax IDs. They can also use both. Insurers then report spending for the identified physician groups using this NPI crosswalk. Oregon didn't have a provider directory, and so what it chose to do when it asked payers to submit data was they asked them to report provider organizations by their tax ID numbers, and they are building a provider directory based on the baseline data submissions for their cost growth benchmark program. They collected the data this past fall, and they're currently analyzing it. And they're going to use it to decide which provider entities the state will publicly report in terms of performance against the benchmark. Rhode Island identified its largest accountable care organizations. It's a very small state, so there aren't a lot of them. In fact, you can see all of them here. These aren't the largest, these are the only ones. And some of these do both commercial and Medicaid business, some just do one. And the insurers are responsible for identifying which PCPs are affiliated with which of these ACOs. Connecticut is doing something similar. It initially, for its baseline analysis, collected data for the 11 largest provider entities. It plans to expand that when they report on performance for 2021, which is the first year of their benchmark. Okay, so these are a little bit of detail on how these states have done this work. The PPC supported the creation use of a state provider directory, if feasible, and DHHS has agreed to evaluate the feasibility of creating a statewide provider directory. If it's not feasible, the fallback option would be to rely on payers, as Rhode Island and Connecticut have done. So my question now for all of you is, what do you recommend?
Michael, this is Bill Welch. I guess the question that I would ask, do we have a statewide provider directory? I've served on several committees over the years, and those various committees that I've served on have attempted to identify the providers in the state. And my experience tells me that none of them were ever very accurate. So is this something the state's going to have to create? And if so, how long will that take to do?
Yeah, so to my understanding, Bill, is there's not one today. And so the request of the PPC was that Health and Human Services perform a feasibility assessment. I think that will probably involve looking at what Oregon and Massachusetts have done and determining, what would it take to do the same thing in Nevada. And then based on that assessment, deciding either to pursue one of those two paths or default to the approach that Rhode Island and Connecticut have used.
This is
Michael?
Angela. Go ahead, sorry.
Sorry, Angela, I was just going to follow up question. Thank you. Michael, if understanding there is not a provider directory, if the fallback position in the interim, because I don't know how long that will take to build a accurate one, I think that could be a year's times period or possibly even longer. But if you went by the contractors, the providers based upon the payers based upon who the providers are that they're contracted with, how do you eliminate duplicity? Because many of your providers will be contracted with multiple payers. So how will you narrow it down so that you're not picking up a provider multiple times and getting a larger count of providers than what we really have?
So, I mean, the task, Bill, is really for the insurer to say which primary care providers are part of which larger entity. And so if I'm, let's say, a commercial insurer and I'm contracting with a medical group, then I'm probably going to know who are the physicians who are part of the medical group. If I'm contracting with an IPA, I'm probably going to know who are the physicians that are part of the IPA. So it's unlikely that we're going to get duplicate reporting of the same primary care provider for different groups, because the payers really need to know which PCPs are part of which group or which IPA. One other thing, Bill, I'll just note, in terms of the timeline to do this, if Nevada did the same thing that Oregon did, then you could collect the data during the baseline data collection. The baseline data collection is looking at what was trend before the benchmark became effective. And so it's possible that you wouldn't need to add any time on if you took Oregon's approach. Now, is Oregon's approach going to be feasible for Nevada? I can't say. But if it was taken, it wouldn't add time on.
Thank you.
Then my question is, I guess, more patient centered. Like, I wonder of the approaches, do you have thoughts on which one is easier for patients to access? Which one's just the common person? What would make it easier? Like what you said, Rhode Island's really small, so maybe their systems work because of the size. And so I wonder, what are your thoughts on which approach would be more patient centered?
I don't know that either is more patient centered, to be honest. Yeah, and this is sort of calculations going on that patients frankly would never be aware of. Because this is really about connecting primary care clinicians to provider organizations. So I don't see a patient-centered implication for that exercise.
Okay, just curious, since I know that's our focus. So
Yeah.
wonder.
Yeah, it's a fair question to ask, but I don't think it matters. Karen, were you going to say something?
I was. So I may be jumping ahead, but I think it'll help me have a more informed opinion about this part, which is what about for instance, there's a new practice in Northern Nevada that is primary care their focus is to be independent. So for people who choose that path or who are affiliated with multiple ACOs or IPAs, which is not uncommon in our market, how do they roll up?
All right. So if they are independent and they're not affiliated with anybody for anything, they don't roll up. They would be reported by the insurer in a big pool of primary care practice organizations that are small and independent. Okay.
So my follow-up question is either one of these more dynamic in terms of a provider taking their NPI, leaving one system, going to another one in town? My gut feel is that working off contracting arrangements might be more dynamic if someone splits a year.
Yeah, the Massachusetts approach where they crosswalk individual clinicians to medical groups, that's going to be much more stable over time than imagine. Well, you cited earlier that you might have a practice that participates in multiple ACOs. So maybe it's in ACO A for Medicaid, ACO B for commercial, and ACO C for Medicare Advantage, right? So, when you're doing measurement that way, you're getting a lot less stability and consistency than if you said, no, that practice is part of this entity, and it's not going to change based upon the contractual arrangement.
Thank you.
Yeah, I think the states that have gone with contractual arrangements have done so because they didn't have a provider directory, and so it was the next best available option to them. It wasn't that they thought it was the best approach, but it was the most operationally feasible approach. But the implications are that you could have primary care providers winding up in more than one organization. I will say that that's probably not a really big issue in a little state like Rhode Island, where you just don't have that many complex relationships, but certainly in a larger state, it might happen.
I think you don't have the complex relationships, but you may have individuals with NPI numbers moving from one to the other more frequently.
Yeah. Well, and you're also, regardless of the size of the state, you're going to have clinicians who are going to move from one organization to another year over year.
Yeah.
Right. That's always going to happen.
Thank you.
Yeah. All right. Anybody have any input on recommendation to the PPC on what they were leaning towards? Do you support it? Do you have a contrary opinion? No? Okay. So let me move on. I'm going to move on to some more challenging topics. So now I want to talk about methods to ensure the accuracy and reliability of performance measurement. So for those of you who are part of a provider organization, this is about, and frankly, insurers too, how do you make sure that when the state reports out your performance against the benchmark, that it is accurate and reliable? So why is this a concern? Well, there is a lot of random variation in service use and medical expenditures, and that will impact per capita cost growth of entities with small populations. And when I say small, I mean statistically small. So in statistical terms, a couple thousand people is tiny. And I say it's tiny because it doesn't take a lot of random variation in that population for per capita spending for that patient population to zoom up or to come crashing down. It's only a couple of patients, maybe only one patient will cause a giant increase or decrease in spend year over year. So,
Mike,
yeah.
Sorry, this is Kyra. I have a question just regarding that piece, and I don't know if it's appropriate to discuss it now, but from the analytics perspective, when we're quantifying this cost growth per capita, should we employ some kind of methodology that would actually exclude those heavy hitter outlier patients? I mean, do we want to have those people included in our general cost growth benchmarking, or do we want to say, you know, that they exist, but they are this tiny percent of the population, and maybe they aren't as applicable to the main analysis? I'm just curious how we should handle those.
Kyra, hang with me for no more than 5 slides because we're going to talk. Yeah. So payers and provider entities both have to have enough members or patient volume to accurately and reliably detect changes in per capita expenditures and to minimize the presence or absence of a few unusually complex and expensive patients, which is what you are referencing, Kyra. So we've got to find a way to minimize the impact of swings in very sick patients. Okay, because when judging performance against the benchmark, we don't want the judgment to be impacted by random variation, because that's going to result in an unfair assessment. That could swing either way, right? That could be to the benefit or the detriment of the payer or the provider entity. And I include payers because we're measuring payers by line of business. And in a competitive insurance market, when you're looking at it by line of business, in statistical terms, that even numbers, let's say 10,000, are still going to be impacted by random variation. So there are a host of strategies that we can implement to reduce the chance that random variation is going to significantly impact performance against the benchmark and increase our confidence in the performance assessment the state's going to perform. And these are the 4. Kyra, you can see here, mitigation of the impact of high cost outliers, that's number 2. So I want to walk through each of these 4, both to educate you, but also ask for your feedback. So by minimizing the impact of small population size, we want to increase our confidence. We also, though, need to consider other factors: data completeness, the payer's data reporting burden, and the burden on state staff to collect, validate, and analyze data. Because the greater our effort to increase confidence, the more work involved for both payers and for the state. All right, so method number 1 is performing statistical significance testing. So DHHS could develop confidence intervals around benchmark performance. This would show us the range of values within which we're pretty sure the actual performance rate lies. And it would allow us to say we are 95% confident that between lower bound A and upper bound B contains the true cost growth for Acme Medical Group. So this is what confidence intervals look like. Let's say that our cost growth benchmark is 3.2%. For payer A right here, payer A, this is the confidence interval, this horizontal line. This dot is the actual rate. But the confidence interval says, well, performance really could be anywhere between the upper and lower bounds. Because payer A's bound intersects with our cost growth benchmark, it means we're not really sure whether payer A was above or below the benchmark. Payer B, full confidence interval is above 3.2%. So we would say, no, payer B did not meet the benchmark. We are confident in that, 95% confident. And then provider organization C, fully below this line right here. So we would say we are confident that provider organization C met the benchmark. You'll note also the size of these horizontal lines varies. The width of the confidence interval will often correlate with the size of the population. So a small population will have a really wide confidence interval, and a super large one will have a narrow confidence interval. All right, so one option is to report performance each year for payers by market and for large provider entities by market using confidence intervals. Oregon, Connecticut, Rhode Island were the first states to adopt this. Oregon developed the methodology, which Connecticut and Rhode Island then copied. And all three states are now analyzing data for reporting in early 2022. Washington also has adopted it. They haven't yet done their baseline measurement. Massachusetts methodology is in statute and it lacks confidence intervals. And Delaware's only reported the state and market level yet. And so they haven't used statistical testing. So the PPC recommended applying statistical testing in the use of confidence intervals to determine whether payers and provider entities have met or not met the benchmark. Do you all think this is a good idea? And what would be your feedback to the PPC?
This is Kyra again. I mean, my only feedback is that from our perspective as the group doing a lot of the analysis, it would be easy for us to include confidence intervals, so I don't see a downside.
Great, thanks, Kyra. Anybody else? Right, does the silence mean this is too complicated or what? How do I interpret the lack of comments from all of you?
I think it means we're okay with it. For me, I think the use of confidence interval strengthens it and
Okay.
Adds a level of credibility.
Okay.
So it takes my silence as assent.
Okay, yeah, it's good for me to hear assent because we want to feed back to the PPC what you all think. So even a quick yay sounds good. That's helpful.
I'll throw in a yay.
Thanks, Maya.
Well, Michael, I'm a yay, but I do have a question.
Sure,
You mentioned that one or two patients in small groups could throw it off significantly. Has anybody ever tried to take, say, the top 10% or the top 1% or the top and the bottom 1% and drop them off to try to narrow those variables?
Yeah, we're going to talk about that strategy next, Bill.
Okay, thank you.
Okay, it's not in conflict with the confidence intervals. So we're going to talk next about how to treat the high outliers. And actually, we will, if we address the high cost outliers, we will actually narrow the confidence interval. So it will actually increase our ability to, with confidence, say yes met or no didn't meet.
Yeah, that would be my thought too. Thank you.
Mm-hmm.
And are you going to talk about risk adjustment?
Yes.
Okay.
Yeah.
Thank
Yeah.
you.
We're going to talk about risk adjustment. That's number 3 in our strategy list. It's maybe the most complicated topic we're going to get into, but we are going to talk about it. All right. Thank you all for your feedback. All right. So everyone's eager to talk about high cost outliers. So These are members or patients with extremely high levels of annual healthcare spending, sometimes only for 1 year. They represent real spending. And so when we look at state level trend, we need to include that spending. And there are, very high cost patients or members every year, but they do present, for the most part, randomly in a population. And there are also some limits on how much a payer or a provider organization can manage their expenditures given the complexity of their conditions and their needs. And I would say, my opinion is it's not fair to judge an insurer or provider's performance against the benchmark based on the influence of high cost outliers, either their addition or their subtraction. Because maybe a medical group had 5 of them 1 year and they had 0 the next year. It's not fine to judge them for the increase to 5 or the decline to 0. So it's common practice in total cost of care contracts, also known as ACO contracts, to truncate expenditures to prevent a limited number of high cost members from affecting per capita expenditures. Truncation means capping individual spending, patient spending. So you're not tossing all of the spending for those patients, but rather you're saying anything above the truncation level, we're not including. In commercial population contracts, that level is often between $100,000 and $150,000 per year. It can be different for Medicare Advantage and for Medicaid contracts. So if it were set at $100,000 per year, we would include, for a patient who had $200,000 of spending, we would include $100,000, and then we remove the second $100,000 for the purpose of measuring payer and provider level performance. We would include all of the spending and looking at market level trend and in state level trend. So this is only for payer and provider entity, and that's because we're going to be, through public reporting, holding them accountable for meeting the benchmark. And so we want to be fair for holding them accountable when we're publicly reporting. Okay, and I think I just explained this in my comments. So a little bit of information on the impact of high cost outliers. In Rhode Island, their first year, they did not exclude high cost outliers, and it dramatically impact the trend of provider entities. For one ACO, high cost outlier spending raised the trend rate by several percentage points. So the organization went from being under the cost growth benchmark to about 3 times the cost growth benchmark. Okay, and that was just due to high cost outliers.
Mike, sorry, this is Kyra. I have another question here.
Yeah.
I'm going to ask a lot of questions because I'm thinking of how we're going to actually do this as we go through. So I just wanted you to clarify, because in the last slide, you just previously had said that we would continue to keep the high cost outliers in analysis that we did, at a higher level before we break it down into markets. But then I'm confused how that relates here to Rhode Island. So if they had this high cost outlier that raised their trend several percentage points that made them, exceed the cost growth benchmark versus not exceed it, doesn't that imply that you would want to pull it out of that statewide?
Oh no, this was at the ACO level.
Okay.
So there was an individual ACO, and I don't remember the exact numbers, but we fed back data to them and we said, well, according to data submitted by the payers, your trend was 11%. And they said, what are you talking about? In all of our ACO contracts, our trend was 3%. Okay. So we went back to the insurers and we said, insurers, what's going on? And it turned out the high cost outliers boosted the ACO's trend from 3% to 11%.
Okay, so then I'm just trying to wrap my head around, if we have this analysis that starts at a very high level, and then essentially you have all these drill downs to get specifically into payers and providers, couldn't you find yourself in a situation where your high level analysis showed that you were significantly, as a whole, as a state, we were significantly over the cost growth benchmark because you're including all these outliers. But then when you drill down into specific payer providers to identify exactly what's driving that statewide growth, you wouldn't necessarily be able to follow that. Do you see
Yeah,
what I'm
so
saying?
the outliers are going to wash out because you have outliers every year.
Okay.
So at the state level or the market level, they're not going to cause a lot of turbulence, but they are going to cause turbulence when your numbers get smaller and you're looking only at commercial patients for one medical group.
Okay.
And remember, the high cost outliers come and go. So, the medical group that had a whole bunch one year might have none the next year. So that's why you're not likely to see a disconnect.
Michael, I have a question for you. When I think of a high cost outlier, and please correct my assumptions if they're wrong, I think about someone that may have like a burn victim that ends up in the ICU for multiple months, or, like a child that ends up in the NICU for like a year because they're waiting for a transplant or something like that. Are there certain providers that are more likely to have these outliers than others? Is that, like, I would imagine like a community physicians organization would be less likely to have these high cost outliers, whereas like a level 1 specialty trauma center would maybe be more likely, or, a hospital with ICU capabilities would be more likely to have.
Yeah, so remember, so these are randomly appearing patients. And so the patients who get referred to the level 1 trauma center, the level 1 trauma center is a regional resource. And so it's going to be serving patients who are served by primary care clinicians from all over the place. Because all of our spending traces back not to the facility, but to primary care clinicians. So people aren't going to be attributed to a trauma center. They're going to be attributed to primary care clinicians. And all of the patients who need level 1 trauma, they're all going to go to the regional level 1 trauma center. Does that help?
Yes, that helps and explains why it wouldn't necessarily be appropriate to attribute like a burn victim's 6 months stay in a hospital to a primary care physician. So, thank you.
Yeah. So, for the reason that I just shared, Rhode Island decided to truncate high cost outliers starting with 2020 performance data. And they set different truncation levels for Medicare, commercial, and Medicaid after consulting with insurers. So the commission leaned towards supporting truncation of high cost outliers and recommending an analysis of outlier spending to identify its causes and opportunities to slow spending growth. They didn't come to closure in this conversation because we ran out of time. So I'm not asking you here today to agree with the recommendation because they didn't quite come to closure. So let me ask you, do you recommend that there be truncation of high cost outlier spending when measuring insurer and provider entity benchmark performance?
It's Kyra again. I'm just jumping in here because nobody else.
Thank you.
So, I agree with the recommendation. I think it's important also, though, and I think this is what they're recommending as well, to apply that truncation, but then also try to quantify, like, what is that dollar amount that we're truncating? Because it just seems like we would also complementary want to understand that as well, which I think again, that's what they're saying too, recommending an analysis of outlier spending kind of separately.
Yeah, well, so their discussion was, but hey, outlier spending is real spending. And so we need to understand it and understand if there are opportunities to slow spending associated with high cost outliers. I think that's what they were getting.
Right. Yeah.
It's not just write it off.
If I can add one sentiment to it that I think everyone's probably thinking about is I think the truncation and the risk adjustment are really important to the public, because I think it's important for the public to feel that there's not something in place that is encouraging people to limit their care. I mean, you see a lot of angst about that in the public, even now, with the perception that people aren't going to give them the care that they should have. Because there's other incentives at play. And so I think just for the public to feel confident that there's not a perverse incentive about that is really important.
Mhm. Thanks, Karen. Anyone else have a recommendation on high cost outliers?
So this is Kyra again. I would just wonder if the amount that we choose as that cutoff is something that would need to go to the PPC, or is that something that we could get with you? Or
Yeah, I don't think so.
okay,
I think that's something that that you could work at. I would suggest engaging some payers, maybe provider organizations, to talk about what makes sense.
okay,
Yeah, and I can certainly share with you what are the values that they adopted in other states.
okay, yeah, that would be very helpful. Thank you.
Anybody
Michael,
else have a- Yep. Sure.
I support truncating out the high cost outliers, especially given that you might not have the statistical power for a particular individual provider to be able to handle those kind of outliers statistically.
Mm-hmm. Okay, thanks. All right, thank you all for lending your voice so that we can convey it back to the PPC. All right, someone, I think Karen asked about risk adjustment. All right, ask and you shall receive. This is a complicated topic. So get ready to go for a ride. So cost growth benchmark is typically risk adjust data to account for population changes over time. Why? Well, a payer or provider's population can change over the course of a year. And those changes in population could impact spending growth. Okay, that probably all is straightforward. So clinical risk adjustment is an approach that uses conditions diagnosed and treated during the performance year and sometimes during prior performance years to predict spending. Available models use claim data, relying, I would say, most heavily on diagnoses, sometimes procedures and prescription drugs. They don't use medical record information. And the best risk adjustment models can explain about half of the variation in healthcare spending, which is a lot. And even a little more if you exclude the high cost outliers. Okay, and you can see a source here, report from the Society of Actuaries that compare different clinical risk scoring models using claims. So in other states, risk adjustment's been applied at the insurer and provider entity level, not at the state and market level, based on the judgment that an overall state population just isn't going to change in its health status all that much from year to year, nor would it at the huge numbers at the market level. But it could at the insurer provider entity level if there was a big change in an employer group coming or going for an insurer, or a provider entity maybe merging with another provider entity that might change the basis of its patient population. So the health status of a population, full one, is typically pretty stable over years because the demographic and health characteristics that affect a risk score occur very slowly. However, clinical risk scores can change more significantly on an annual basis without any change in the population's health, simply based on improved documentation of a patient's health condition on claims, especially the inclusion of diagnoses on claims. So the population might remain stable, but clinical risk scores using claims might be dynamic. Okay, so this is the relationship of coding completeness and rising risk scores. So Massachusetts has studied this, and they've observed steadily increasing risk scores that grew 12% between 2013 and 2018. They looked for correlating evidence that the population's health status had worsened, and they could not find any. And so they are now recommending evaluating payer and provider performance based on unadjusted spending, because it's been their assessment that all of the changes that have occurred in risk scores have been a result of changes in coding and not due to changes in population health status. In Rhode Island, from 2018 to 2019, payer risk scores grew 4.6%. The effect of this increase in risk scores was to effectively double their cost growth target from 3.2% to 6.4%. So that means an insurer or provider could have had a trend of 6.4% and be judged to have met their cost growth benchmark because of the adjustment resulting from this 4.6% risk score increase. So for this reason, Rhode Island decided to only risk adjust data by age and sex starting in 2020, and Washington recently decided to do the same. All right, let me pause here. People following what I'm talking about.
Yes.
Okay.
Michael, this is Kyra again. I have another like in the weeds question. Let me know if we should take it offline. But I guess my question here is this, I'm following all of the risk adjustment stuff, except risk adjustment needs to be done at the claim level. So it would have to be done by everyone, all of the individual agencies that would be submitting the aggregate data to the Office of Analytics. It's not something that we would be able to do on behalf of the data when we're putting the information together into a larger report for the state, correct? Because we won't have claims level data for those aggregate sources. And so I just envision this being very difficult to accomplish because the expectation, I think, would have to be that each of those entities who is submitting their aggregate information would have to have risk adjusted it
Right.
prior
So
to submitting.
Right. So in Massachusetts and Rhode Island, they have historically had the insurers submit risk scores.
Okay.
And using whatever risk grouper software they're using.
Okay, and is that a topic that we should probably discuss as we're identifying this methodology for these
Well, let's go through
Okay.
go through the recommendation on what to do first.
Okay, jumping the gun, sorry.
Yeah. So one other piece of information. This is from a recent paper in Health Affairs. So it's really interesting. So they compared HCC. HCC is a CMS claims-based risk grouper. They compared risk scores from 2013 to 2016 to risk scores based on a CAP survey that asks health status questions. They found that the claims-based risk scores grew 2.1%. The CAPS-based risk scores grew 0.3%. So you can see in boldface here, suggesting that coding may account for most of the observed risk score growth for ACO beneficiaries. It's essentially the same finding that Massachusetts had, but done independently, comparing claims-based risk scores to self-reported health status risk scores from a patient survey. Right, so there are a few options for what to do for risk adjustment. So option number one that I want to present is to do adjustment using normalized clinical risk scores. So here we would say, look, there are changes in populations that occur, but we want to normalize to control for the impact of increased coding or coding completeness. So under this approach, state would use an APCD. Nevada doesn't have one yet, so this would be a theoretical for the future. And in order to do it at the health plan level, but you could have the insurers do it at the provider entity level. So the provider entities, for example, could say, we're going to calculate risk scores, and we see overall across our whole health plan that our risk score went up 2%. So for every provider entity that's above 2%, we're going to normalize to 2%. And for provider entities that were below 2%, we're going to normalize to 2%. Okay. This can only be done for insurers at the provider entity level. The only way you can do it at the health plan level would be using your APCD, which you don't have yet. I will note that there are some who argue against this approach because they say this still does not remove the provider and plan incentive to increase coding completeness. It just increases the motivation to get better at it so that you can beat the normalization. Okay, so this is option number one. Option two, adjust performance data using age, sex factors only. The argument here is clinical risk scores overcompensate for changes and create distortion. Age, sex will capture perhaps the most significant impact on population health status, which is aging. Okay, the downside is if there are other substantive changes in the health status of the population, you're not going to get it at it through age, sex. And we know from that Society of Actuaries study that these clinical risk scores do explain a lot of variation. And so you're going to be giving that up. Right, and this is the approach that Rhode Island and Connecticut are using, and I think Washington. And then the third approach is what Massachusetts is doing, which is don't make any adjustment. Okay, so 3 options. The PPC has not discussed these options yet. We ran out of time at the last meeting and we didn't get to it. So what do you all think? This is not an easy question.
So this is Kyra again. I just wanted to bring something up that I think might help inform the conversation. So the study you were showing with the HCC risk adjustment method was a study that took place from 2013 to 2016, I believe. And that's right around the time the Affordable Care Act started really requiring risk adjustment, right? For commercial payers. And so I just wonder if that study, because of the time frame it spanned 2013 to 2016, is actually inherently going to show a significant increase in risk in the coding behind the clinical risk score, because that's when the Affordable Care Act went into place, which required these payers to risk adjust their populations, right? So yep. Then I just wonder if it has since stabilized and maybe the concerns around the enhancements to coding, because we're so far out from that, maybe we're kind of like there and we have good coders and they're more stable now. I don't know. I just wanted to
I would think the same thing, but when I talked to the people at the Massachusetts Health Policy Commission, and they've had their cost growth benchmark since 2012, they say they are still seeing 2% a year growth in risk score every single year. And in data that we've reviewed for Rhode Island for the last 3 years, we've seen the same thing. So you would think there would be some point where you just can't include any more diagnoses on claims, right? There's got to be some limit. Yeah, but that we don't seem to be there yet.
Okay.
Karen?
So working with medical practices, I feel compelled to chime in on that point. Providers are challenged every day to enhance their documentation, to support why they ordered a diagnostic, to support why they're requesting an admission, to all these things. So I think we benefit. There are many downstream people who want robust records so they can understand the complexity of cases and the necessity of care. So I'm not sure we're at cross purposes to adopt the idea behind number one. I think it just is what it is. I think people are putting more in records because people are requesting more information to understand the care that's taking place.
And we've created incentives for them to do so.
That's right.
right?
And then the other comment I would make is even if patients are attributed back to primary care, not all primary care is the same. So there's community centers that focus on folks with behavioral health or substance abuse disorders or things like that have adopted to care for very complex patients just by the nature of the populations they serve. And so I'm not sure that you can capture that all with age, sex. So I'm sure my comments would point to my probably having more affinity with number one.
Yeah, do remember though, Karen, I just want to point out that when we're talking about doing adjustment, it's not to compare across organizations. It's only to assess change over time. So
Okay.
if you've got a practice that specializes in patients with, chronic conditions, all we're doing is measuring whether their per capita spend changed from year 1 to year 2, not that they compare to Acme WellCare down the street.
So if someone adopted a new specialty with it, like decided to serve a certain population or expand their chronic care or something like that out of their primary care, you might see that bump in a group.
Yeah, but remember, we're only doing this for really large populations. This is never going to be for an individual practice, right? This is going to be for a huge medical group or a hospital system or a big IPA. Because we need, for statistical stability, we need tens of thousands of attributed lives.
Thank you.
Mm-hmm. Yeah, great questions and comments.
This is Larry Lerner. I'd just like to say, for my one-person perspective as a subspecialist, that I've seen documentation bloat over the last 5-6 years. And in my opinion, a lot of the documentation does not improve clinical care. Apparently, it's just to change the risk score and include a lot of diagnoses that are totally non-treatable at this point in time. They're past events that are not really contributing to the current problem. So in my opinion, I think the age sex cannot be gamed in any way, shape, or form. It does capture some of the risk adjustment and may help eliminate some of this incentive to bloat the clinical record.
Okay, thanks, Larry. Ashore, were you going to say something?
Yeah, I have a question about number 2 and then a comment. So my question on number 2 is for the other states that have considered age and sex, why it was limited to just age and sex for demographic factors. And then my comment is, as we've learned more about health disparities and the disproportionate impact that certain diseases have on Black and Brown communities and the discrimination in the healthcare system, why we wouldn't also want to capture race and ethnicity to track and account for health disparities.
Yeah, great question. So I have a few thoughts on this. First is collection of race and ethnicity data by payers, especially private payers, remains quite poor. Commercial insurers, by and large, haven't collected these data at all. And even when states do so, or when Medicaid does so through the eligibility process, there are a lot of non-responses. Additionally, what makes this even more complicated, even if you had full and complete data, it's not clear what the relationship is between race and ethnicity variables and healthcare spending. And when I say that, I mean, there are forces pushing in two directions. One is people of color, by and large, in the US tend to have poorer health status. And so you would think, well, that means, more medical need, more spending. they also can have poorer access to services. So you can actually harm equity by adjusting for race and ethnicity, because if people are underserved, then you're actually going to adjust down your spending for race and ethnicity. So it's a really good question. I just don't think we're at the point right now where we can make adjustments based on race and ethnicity, and do so in a manner where we don't think we would be creating more harm than good.
Yeah, that's a really thoughtful response, and I appreciate that. I think, as we go through this, maybe it's not in risk adjustment. I just think as we have learned more, especially in the COVID-19 pandemic, about these health inequities and disparities, that we really keep that in mind as a state that is new in developing this. And maybe even look to some experts in those communities to see where we can capture it and learn more about it, because I think it's just such an important area that we shouldn't, just because we don't have the data and we don't know. I think we need to start thinking about, well, how can we get the data and how can we know and make informed decisions?
Yeah. So I have a couple of suggestions there. So way in the beginning of this meeting, I had a slide that had a line in the middle, and I distinguished cost growth benchmark analysis from data use strategy. That other side of the graph of the slide that we're not talking about today is about doing analysis at the claim level to understand such sort of what's under the hood. I think that when Nevada has an all payer claims database up, it will be able to do more. So for example, there's another state that we're working with, it's got a cost growth benchmark, and they took the claims in their all payer claims database and they married it together with race and ethnicity data captured at the community level through the Census Bureau. And they were able to profile, for example, disparities in ED utilization by race and ethnicity. So when you have an APCD up, you will be able to do things like that. Okay. The other opportunity is to improve capture of race, ethnicity, language, disability status, sexual orientation, et cetera, by both payers and by provider organizations. And there's another state we're working in that is endeavoring to create standards for data capture for all those variables by both payers and by provider organizations. So everyone's using the same categorization schemes for capturing data so that you can do meaningful analysis. So that's clearly outside of the scope of today's conversation, but it's a potential opportunity.
Thank you.
Yeah, thank you. Anybody else want to weigh in on these three options? I think the PPC would really like to hear from you on these because they haven't discussed this yet, and this isn't an easy decision.
Michael Kyra again. I would just go back to the point about feasibility of getting of the different submitters actually having capacity to risk adjust their data. I mean, I don't know how common practice that is. It probably is common practice maybe these days because it's been around for so long. But I think there needs to be consideration on if agencies are going to be able to submit their data risk adjusted.
Yeah. So obviously number 3 is the easiest for you to do when there's no adjustment. For number 1, if you wanted to normalize, again, you could only do this at the provider entity level because you couldn't do it at the insurer level. But you could ask the insurers to normalize for you when they submit it. That wouldn't be a tremendous amount of work for you. Number 2 is a little bit more work for you. Well, it depends how you do it. You have 2 choices. One is you could develop your own age sex factors. So you could have the payers report spending by age sex cell and then determine what the age sex factors could be. Or you could borrow from someone else age sex factors, which basically say, male 50 to 65 is 1.3, something like that. Okay, so you wouldn't calculate it using Nevada data, but you would say, all right, it's probably not going to be all the different in our state versus any other state. So you could either build it yourself or you could borrow it from a third-party source. If you build it yourself, it's a little more work. I mean, it's doable. It's basically, arithmetic, but it's a little more work. Or you just borrow the age sex factors from someone else and you do the adjustments on your own, which isn't that complicated.
Yeah, that makes sense.
Okay, Bill, Maya, Angela, anybody else want to weigh in?
This is Bill. I support trying to do something with the clinical risk scores if possible, but I do understand the challenges that you've identified, Michael.
Okay.
In Kyra, the work that you'll have to do, but I do think it's the best approach for now.
Okay, thanks, Bill.
I think we're still kind of assessing this and digesting it, so we may follow up later with some comments.
Sure, that's fine. I understand that. This isn't easy.
Hi, this is Stacy. I agree with Maya. I just want to spend a little bit more time understanding this before I can give full opinion.
Okay, thanks, Stacy. Yeah, and if you have follow-up questions for me after the meeting, feel free to reach out.
Thanks.
Mm-hmm.
Michael, this is Chris Bossy. Apologize for joining late. Just in terms of this specific element, I guess from my perspective, the reason I like the idea of normalizing clinical risk scores is I would hope then in doing the normalization, it then leaves you with information that's more actionable. You don't have as much noise around, oh, why are the costs going up? Oh, well, I can see I've taken out the variation in the clinical component, and now I can focus on what's left. And so it feels like what's left is more actionable.
Okay, thank you, Chris. Okay, so it sounds like we've got some variation in views, not surprising. We will we'll summarize what you all have conveyed to us and bring that back to the commission at its meeting in mid-February. Again, they haven't talked about this yet, so it will be good for them to hear from you. All right, last topic, reporting for sufficient sizes. So there's a question, or three questions actually, that related to sufficiency of population size. How many enrolled lives should a payer have to report its total healthcare expenditures? How many attributed lives must a provider entity have for their total medical expenditures to be reported? And how many lives must a dyad of a payer and provider entity have in a line of business to be publicly reported? So here's what other states have done in terms of picking which insurers should report. Delaware and Rhode Island said largest insurers in the state, they didn't have many insurers. It wasn't a hard decision. And then for public reporting of provider performance, they said 10,000 attributed lives for commercial and Medicaid, 5,000 for Medicare. Connecticut picked the insurers that represent 85% of the covered lives in the state. And they have not yet decided on thresholds for public reporting of provider performance. Massachusetts has a really low threshold. Payers with 3,600 attributed lives have to report to the state. They have no public standard for public reporting, so we don't know how they decide. In Oregon, they also set a pretty low threshold, 1,000 covered lives across all lines of business, and insurers have to report. That is super, super low. And then for reporting, provider entities with 10,000 attributed lives across all markets. So there's a lot of variation here in approach across these states. Now, sufficient population size is a little less pressing when we've got confidence intervals, because ultimately, if you've got populations that have confidence intervals that are so large that you can't ever determine whether someone has or has not met the benchmark, then you know that your population is too small. Oregon and Connecticut have collected pre-benchmark data. In fact, Connecticut reported out their pre-benchmark data just this week. This is probably going to lead to some insight into confidence intervals that are so large as to make it really too difficult to determine benchmark performance. And so I think that it's going to be possible to use these confidence interval analyses to figure out that by default, a population needs to be at least size X to make it worthwhile to collect their data, both at the insurer level, but also at the provider entity level. So our recommendation is require reporting by all the Medicaid MCOs and by carriers with market share of 5% or higher for now. And then defer on provider entity thresholds until Oregon and Connecticut have finished their pre-benchmark analyses, and then come back and recommend a threshold for how large a provider entity should be at the provider entity should be in order to ask insurers to report data for them. Any questions about these recommendations? The PPC has not talked about this yet, but does this seem sensible to you or not?
Michael, this is Bill. Understanding that we want to get as much data as possible from all folks, how many payers, do we have any sense of how many payers in Nevada would fall under the 5%?
Yeah, boy, under it or over it?
Well, what I'm understanding here is they have to have 5% of the market share.
Yeah,
and
so how many are captured?
Yeah.
Stacy, can you look this up? Because we figured this out before, and I forget. There was a pretty clear break, Bill, when we looked at enrollment.
I just want to make sure that we're not inadvertently, by folks under 5,000 or 5%, excuse me, we end up with a measurable portion of the population that's not being accounted for.
Yeah, we figured this out too. We figured out what percentage of the population we were capturing when we set it there. Stacy, can you look this up?
Yeah, I'll take a look.
Okay, all right. So Bill, hold for a minute while she's doing that research, because we know the answers. I think we actually know the names of the carriers as well.
All right, thank you.
Yeah, I think we get a pretty high percentage of the market. Anybody else have questions or reactions? Yeah, all right, so let's wait a second for Stacy to look up the information that Bill just asked for.
Is this 5% calculated January 1st of every year, or how's that technically work?
So I think we use data that the insurance department captures on enrollment. And I don't remember, Larry, how they collect it. But they get filings, regulatory filings from insurers. So I don't know if it's the average membership over the year or the membership at the end of the year.
But this is calculated yearly to figure out.
Yes, yeah, it's calculated yearly. Mm-hmm. Yeah, so the list could change.
All right, Michael, I have it pulled up. So I think it was we rolled it up into the parent companies. So Renown Health had 5.11% market share. That was the lowest percentage of what qualified. And then Humana at 13.33%, Anthem at 20.91%, and then United Healthcare at 47.9% market share.
And what does that total to? Those four?
The total, let me
Market share.
87.24%.
Okay, so Bill, that's lion's share of the market.
Yeah, it would be. I was just thinking about the small group, small plans. I was on the Division of Insurance Advisory Committee for adequacy of network standards. And there's a fair number of payers who fall into that category, and they wouldn't hit that threshold. So at some point in time in the future, that might be a population that I think would be valuable to be taken a look at as well.
Yeah, I think, Stacy, remind me, is that just fully insured? Those numbers?
I don't actually, I'd have to look at the email that this came in.
It's probably fully insured. The issue, going back to Bill, is that if there are carriers who have almost no fully insured business, but a ton of self-insured business in the state, then we might be missing them. Chris?
Thanks. So are we saying market share is statewide? Or is it based on, is it more regional? How are we defining market?
Yeah, statewide.
Okay. And then something you just said about, like, we're going to leave out all spending of self-insured, or we're only going to measure on the fully insured, and they'll report all their claims, which will include TPA services.
Yeah, so these four carriers who represent 87%, they would report for their fully and self-insured.
Got it. Thank you.
Mm-hmm.
And what about people with no with no fully insured? You wouldn't capture any of those claims?
So if there are any, well, there are for other, so we've got 87.2% of the market here. If there are carriers in the state that are operating as a TPA with almost no fully insured business, then we wouldn't capture them. So if any of you know of any insurers operating in the state that are all or nearly all self-insured who we don't have on this list of four that Stacy led, it would be good to let us know, because we might want to include them because they might have enormous self-insured that we don't know about.
So Michael, with this line of questioning and conversations going on, as I reflect back on when I served on the advisory committee for the Division of Insurance, as I recall, and I can't quote you exact numbers, but the fully insured represented a smaller percentage of the insured lives if you took into consideration those who were insured through a self-funded plan.
Mm-hmm.
So when we talk about 85%, we're talking about 85% of its world, not of the insured population of the state. Because there's a lot of people who are insured through self-funded plans that I didn't hear you mention.
Right, but these carriers also serve self-insured employers.
Okay.
Right, I mean, United and Anthem have lots of self-insured business.
I do think Nevada may be somewhat different in terms of the proportion of services that are provided through self-insurance. I think we are unusual, and we may want to look at that. So, here's an example. Aetna offers services to state employees currently. So all state employees would be under Aetna, and you're not going to capture that. Or are you capturing it separately?
Yeah, so we don't have Aetna. We looked into Aetna, but they're not actually paying claims, right? They're doing administrative services for state employees.
Yeah, it's a TPA, but that my point is that similar circumstance works for resort employees. It works for, I mean,
Yeah.
there's lots of, for Washoe County, and so they're huge, large employers that don't use the 4 fully insured companies
Right.
that you're describing. That's the
Right.
only.
So the big nationals that we don't have on this list that we could consider adding are Aetna and Cigna. Right. Because though they are 2 big nationals that are in every single state. We've got United and Anthem already. Okay, so the 4 of those are the big 4 national carriers. So we could add Aetna and Cigna, assuming that they're going to have a significant amount of self-insured business where they're operating as a TPA in the state. So, it's probably something worth considering. Even if only to make the request the first time so that we can see what the attributed lives look like. And then if they're too small, then we don't ask them again. Anybody else have any thoughts on this question? It's been a good conversation. No? Okay. All right, well, I thought we weren't going to get through everything, and lo and behold, we're going to get through everything in under 2 hours. So I want to note a couple things just going forward. As a reminder, the big picture here is our model for a cost growth benchmark is to do measurement of spending relative to the cost growth benchmark, analyze spending, not just relative to the cost growth benchmark, but to dig down into what's driving cost growth over time by, in the short term, analyzing Medicaid and state employee health plan data, publicly reporting, identifying where there are opportunities to slow spending growth, and then to identify and hopefully implement strategies to slow spending growth and thereby hit the cost growth benchmark. Okay, so our timeline going forward is, I think we haven't updated this, Stacy. So our plan is to make a baseline data request to insurers. This says March, it's actually going to be June now. So we're going to ask insurers to submit data after they've had training and distribution of an implementation manual. And then we're going to take the summer to analyze the data and then report performance against the cost growth benchmark on a sort of a baseline level. Okay. In addition, Medicaid and the Public Employee Benefit Plan are completing a cost driver analysis. And Medicaid is actually almost done, the Public Employee Benefit Plan not. But it's our intention that we're going to share with you that analysis. It's going to be conducted in 2 phases, phase 1 in March, phase 2 over the summer. And we will then review the findings with you and with the commission and ask you to weigh in on where you think action might be taken to address opportunities to slow spending growth and achieve the benchmark. Okay, the commission also has in its charge that it can recommend up to 3 bills for the legislative session. So it will be talking about that in the spring and summer. And then this is the commission's plan for its meetings over the coming months. Just so you can see that they are going to be doing work relative both to the cost growth benchmark, but also working on their bill recommendations. So we don't have our next meeting date scheduled yet, but it will be scheduled, and Leslie will be in touch with you about that. And our plan is going forward that we're going to begin to meet with you on topics before they go to the commission rather than after they go to the commission. So rather than you responding to a commission discussion, we're going to let you weigh in, and then we're going to bring your ideas to the commission. So we're going to have a little flip in our order of operations going forward. And that will begin with our next meeting. So that's all that I have to share. I'd like to open up and ask for any other questions or comments or feedback on this meeting.
Hey again, I just want to thank you, Michael. I find these meetings really helpful. So I appreciate you doing all of this and taking the time to explain it to us.
Great. Thanks, Cara. Glad it's helpful.
I would agree with that, Michael. This is Bill. I also want to acknowledge and express my appreciation for the switch in how these advisory committees are going to work. So I know that we're not decision makers, but to be in advisory capacity, it would be it's going to be helpful to be able to give some input to the commission before they make their decision. So I appreciate that change in the process. So thank you.
Sure. Thanks, Bill. Anybody
Thank
else?
you, Michael.
Okay.
I appreciate everybody's engagement today. And I just wanted to let you know, I'll be in touch with you regarding future dates. Probably not on Fridays. I had a couple of the stakeholder committee members say they could not make it on Friday. So we'll try to schedule for other days of the week. But until then, I would like to open it up for public comment. We do have an attendee on the, oh, nope, just gone. Okay. I didn't know if we had any public comment. So if anyone would like to make a comment, a public comment, now's your chance. I don't see anybody raising their hand. If there's any other comments? If not, oh. Okay, Ashore had Ashore, did you have any questions? No? Okay, I don't see anything. So we will adjourn now at 10:50, and thank you all so much for attending and all of your engagement. Appreciate it.
Thank you.
Bye, everyone.
Have a great day.
Bye-bye.